Welcome to RAAONLINE. Today's topic is spinal dural AV fistulas. We will describe mainly the diagnosis and surgical management of this disorder in this presentation. So let's try to understand this disease with a short introduction with a index case. A 59-year-old male presented to us with was a known case of systemic hypertension, presented to us with backache with progressive difficulty in walking for 10 years history, and he also had paresthesias in both lower limbs for 8 years and subsequently had worsened to develop urinary retention in 2 years and was in a bed bound or a wheelchair bound status for the past 1 year. On examination he had spastic paraparesis with grade 2 power in both lower limbs. Interestingly, he had 2 surgical past histories where he underwent a C3-4 anterior cervical microdiscectomy in 2005 and subsequently he underwent an L4 laminectomy in 2009 for a possible diagnosis of a lumbar canal stenosis. So if we look at the imaging which was done in 2005 in this gentleman, we find that there is a C3-4 anterior cervical discectomy which had been done for a C3-4 disc, which is causing cord compression and narrowing of the spinal canal is there. We see also some small T2 hyperintensity changes there. We see on the axials that the C3-4 level there is a significant compression of the cord on the left side here, and the cord is severely compressed. So he underwent a C3-4 anterior cervical microdiscectomy, and despite this surgery his symptoms continued to progress. In 2009 the MRI lumbosacral spine showed that at L4-5 level there was a disc prolapse with canal stenosis, and we see that there is nice decompression of the cervical cord at C3-4 level, which was the surgery performed in 2005. So for this L4-5 disc prolapse and lumbar canal stenosis he undergoes a L4 laminectomy in 2009. What we probably see here also is what was missed in these two MRIs in 2005 and 2009 in this gentleman. So apart from that L4-5 disc, we see the laminectomy defect. There is definite subtle T2 hyperintense change starting from the level of the conus and going up in the cord. Also in 2005 imaging, the thoracic cord shows T2 hyperintensity changes far away from the cervical cord compression. So there are T2 weighted changes in the cord seen in the 2005 and 2009 imaging. So finally when he came to us in 2013, we knew that this patient is having something more than just degenerative spine disease. So despite laminectomies and cervical discectomies he had not improved. So in this imaging we noticed T2 weighted flow changes dorsal to the cord, and also we see that the cord edema is persistent as seen in the scans in 2005 and 9, and in the thin T2 weighted coronal cuts we see a nice squiggly vein which is going all the way up this T2 flowoid here. With this index case we will go into the introduction of spinal dural AV fistulas. My talk is confined to the type 1 variety of spinal AV malformations. These are the most common spinal vascular disorder, representing 80% of spinal vascular lesions. They present with an insidious onset, and diagnosis as seen in our index case is often missed up to 60% of the patients. Natural history is usually of a progressive myelopathy, and if left untreated 50% of these patients become disabled at 3 years, just as we have seen in our index patient. So what is the etiopathogenesis of spinal dural AV fistulas? There is an abnormal connection between a spinal radicular artery and a radicular vein. Typically this is seen at the dural root sleeve of the dorsal nerve root right here. So we see that there is an abnormal communication here, and there is a reversal of flow through the vein here. So and we see that the vein has become arterialized and there is a reversal of flow in the vein because of a abnormal connection between a spinal radicular artery and a radicular vein. So this arterialization is usually low flow, and because of this reversal of flow in the medullary veins, the patient starts to develop venous hypertension, which is usually in a caudocranial direction. So, we see usually these T2 weighted changes starting from the conus and going up, ascending up, and because of this venous hypertension there is naturally a tendency to develop decreased tissue perfusion along with the vascular steal phenomenon, and the patient develops cord ischemia, and very rare cases there may be hemorrhage. So, how to address this lesion? It is as simple as it seems in this diagram. An abnormal spinal radicular artery is communicating with the vein, and because of this abnormal communication there is arterialized veins. So, the simple solution to this is to excise the fistula, which is the abnormal communication between the artery and vein. Once you do that, we will have normal flow re-established through the medullary veins, and there will be no increased venous hypertension.